Welcome, welcome, welcome in everyone. Welcome to Care Concierge with Care Patrol, where education is the heart of everything we do. Thank you so much for joining us on this beautiful day, Friday. Happy Friday to you all. I hope it's been a good week for you, and I hope the weekend that's upcoming will be restful and peaceful and recharge you for the next week. Thank you all for joining us today. We're all month long in September, we're focusing on mental health issues, and each of the topics that we're discussing were provided to us by former attendees through the evaluation that we ask you to do at the end of today's presentation. So all topics were suggested by some of your peers, and hopefully the person who suggested today's topic of mental health and drug abuse is with us. I hope so. If not, perhaps they will watch us on the YouTube channel. Hey, Katrina, thank you for being here. It's so nice of you to visit, and you visit often, and there are so many names on the list here that I know and appreciate you continuing to tune in for your contact hours through us. We appreciate that. So again, today is mental health and drug abuse. Let's do some housekeeping as we get ready to move forward. As people come in, those of you who are just coming in, welcome to Care Concierge with Care Patrol, where education is the heart of everything that we do. Thank you all for speaking to me and to one another in the chat room. I love to see folks participate and get value out of what we do. I hope that we do provide you professional and personal value with each of our topics. And I hope that you today, as you do the evaluation, will consider leaving us some ideas for topics that you'd like to see. So we are, as many of you who visit frequently with us know, we're accredited by the Alabama Boards of Social Work and of Nursing to provide and credential and create and offer these CEUs, which we are happy to do. In order, though, for them to be considered live CEUs or face-to-face CEUs, we have to use an evaluation process in which we ask you to complete an evaluation, and it's password protected so that we know, or so that the boards know, rather, that you were not only present, but participated and listened to the education so that you can receive your certificate. Now, some of you may have been some of you nurses may have listened to hospice, or not hospice, but help with medication cost. And that was my fault. I did not post those immediately, and they weren't there yesterday when you checked, and I do apologize. They are there now, and we are very usually good about posting these as quickly as we can, but I made a mistake and I apologize. But we do post all nursing hours to the ABN website on your behalf if you complete the evaluation, and all social workers, in fact, everyone, will receive a certificate along with today's presentation slides. So thank you for being here. I hope you'll use the chat room as you already are, and do remember that you can unmic. So if you wish to unmic and create a discussion for all of us, I'd be happy for you to do that. I would welcome it, but certainly don't want to pressure anyone to speak who's not comfortable speaking. Some of you who are listening by phone, or you're not able. Ms. Hinton, let me check on that. Send me an email, please. And anyone that's missing a CEU or certificate or doesn't see your hour posted, please email me at sbarnes, it's on the screen here, at carepatrol.com, and my Barnes has an ES at the end. sbarnes with an ES at carepatrol.com. If you will be so kind as to take a minute and email me, I will take care of that for you. So let me now read the evaluation link to those of you by phone. I know you depend on me to do so. And the link is https www.surveymonkey.com/all uppercase letters, D as in dog, B as in boy, M as in Mary, M as in Mary, J as in John, 9-3. And I'll read the evaluation link one more time for those of you that didn't have time to make note yet. It's https://www.surveymonkey.com/lowercase r/all uppercase letters, D as in dog, B as in boy, M as in Mary, M as in Mary, J as in John, 9-3. That's our evaluation link for today. It is password protected. Do listen for the password around 12:45. And if I haven't given it, then some of you have been kind enough in the past to remind me, and please do so today if I run over. Today, with our discussion topic of mental health and drug abuse, we have 3 objectives. And one is we just want to discuss common mental health disorders and sort of how to assess how they present visually. 2, to discuss and define mental health and drug abuse signs or symptoms or characteristics and how to diagnose. And then number 3, 4 tips to learn for yourself if you suffer this diagnosis, or for your clients, patients, friends, or family if they do. 4 tips that we can teach to help someone cope and prevent relapse. Those are our objectives. Let's get started. Mental health condition, mental illness, mental disorder. These are all used interchangeably by different organizations. For example, the Natural Alliance on Mental Illness, or NAMI, uses the term mental health condition or mental illness interchangeably. And these would affect conditions that affect thinking and behavior. The National Institute of Mental Health, NIMH, refers to the same as mental disorders. And the American Psychiatric Association refers to these as mental illness. And so mental health conditions then clearly include a wide range of disorders, and some occur with co-occurring disorders. These would include anxiety disorders, which we have discussed in the past, in past CEUs. But yes, Ms. Russell, let me type the link in here in the chat room one more time. There it is. Anxiety disorders, panic disorder, agoraphobia. We've discussed these at length. In fact, we discussed them when we discussed mindfulness a few weeks ago. Depressive disorders, again, we discussed in that case, but characterized generally by low mood, excessive sadness, and cognitive changes. And I think we've talked in the past that it is often difficult with aging adults to differentiate between dementia and depression, because they both present very much the same in terms of the inability to do things like executive function type thinking. And then there's bipolar disorder 1 and 2. And as you know, these folks would sort of spring between periods of mania and periods of depression or low energy. So mental health conditions may include also PTSD, which is we discussed in other CEUs, and I do appreciate seeing all the names here today again. PTSD, which is an exaggerated response after a trauma. And I think we, as I said, when we talked about this prior, we so often think that when we think PTSD, we think a veteran from war who's suffering injuries, emotional injuries from that conflict. But in truth, the majority of people that suffer PTSD suffered some childhood trauma. Now, and we know these lead to things like autoimmune diseases, drug abuse, and other things. So PTSD is the trauma related disorder. Personality disorders may include borderline, as we just discussed, or antisocial personality disorders. And I know I'm wrong in this, and you clinicians will correct me, but I sort of think of borderline personality as sort of bipolar light in a way, and that there are periods of personality swings and mood swings that are similar. And then there's schizophrenia and other psychotic disorders that greatly influence someone in terms of having hallucinations or delusions, paranoia, or other strong emotions or beliefs that simply don't bear out to be true. And I want to pause here. And I do this intentionally because I think that one of the things that will make it difficult for us in Alabama to diagnose mental health conditions, and certainly mental health conditions that are complicated by substance abuse. One of the complications in finding this out in Alabama is that 26% of our state's population is Black. And I think I'm correct in saying this, but I'm happy to be corrected. There are cultural factors and societal pressures and stereotypes within the Black community that influence beliefs about mental health, and thus, decrease those people who will admit to and seek treatment for mental health issues. In fact, in a 1990s public opinion poll, it found that 63% of Blacks polled believed that depression was a personal weakness, a character fault, and only 31% believed it was a health problem. Now, you compound that with the other barrier to healthcare in Alabama for Blacks, which is a general distrust of the medical profession. With good reason. There has been systemic racism throughout the medical profession, and we only need to look at Talladega, to the sterilization trials that happened just last century, just a few years ago, in fact, within the lifetime perhaps of some of you listening. And so we can see then that our clients and patients who come to us who are Black have a barrier to admitting that they have a mental health problem, or acknowledging that they have a mental health problem, or certainly to seeking treatment for mental health problem. In fact, only 1 in 3 Black folks receive mental health treatment. And because of this and other factors, Black folks are not typically included in research, in medical research. And so we have less knowledge about how to treat Black folks because of that. So we're doing a disservice to these folks in our population unless we are mindful of these things and take them into consideration when we are assessing and interviewing them. And the fact of the matter is, we know that we have a problem with this community because Black adults in the US are much more likely to express and report sadness and hopelessness and the feeling that everything requires an effort. That is a sign of depression. That is depression, hopelessness and sadness. And yet we have folks that we're not treating. I've got 4 books here for any of you for whom this topic or little slide may resonate. They are books that will help you if you want to gain knowledge in how to better treat your clients and patients who are Black in terms of mental health issues. There's the Unapologetic Guide to Black Mental Health, Navigate an Unequal System, Learn Tools for Emotional Wellness, and Get the Help You Deserve. There is the Community Mental Health Engagement with Racially Diverse Populations. There is Mind Matters, a resource guide to psychiatry for Black communities. And there's Black mental health, patients, providers, and symptoms. So again, you will receive these slides. If these books are of interest to you, you'll see them there. So I want to ask you then, each of you, and you've been good to chat already today. Thank you. I appreciate that. I want to ask y'all, as clinicians, as a clinician, you individually, have you ever felt that there was more that you could do for someone, but you didn't know what you didn't know? In other words, you perceived a barrier. You knew there was some obstacle to your being able to fully treat or help this person, but you didn't know what it was. It was hidden, but it was there. And you knew that you really could be of help, but you didn't know. So you may not be comfortable answering this question, or it may not have ever happened to most of you. But if it has and you're comfortable, I wonder if this has ever happened. Have you ever felt that you couldn't treat someone because you didn't know what you didn't know in terms of their ailments? So symptoms of depression, we've discussed depression in the past, but just to sort of make the point, which I'm trying to make, which is this is a difficult diagnosis, is that the common signs and symptoms of depression are, as we just said, feelings of helplessness and hopelessness, loss in daily activities and friends, an inability to experience anything that seems pleasurable, changes in weight gain or weight loss, sleep changes, inability to sleep, or erratic sleep or sleeping too much, losses of energy, strong feelings of worthlessness or guilt, concentration problems, which we discussed, which makes it a difficult diagnosis when you're comparing it to dementia. And in men, you can see depression lead to anger and reckless behavior. And so contrasting to that, the symptoms of anxiety would be someone that presents who simply just seems to have common signs, excessive tension and worry, or they appear restless or jumpy, or they report that they're having trouble breathing, their heart is racing, or they just seem to be on edge. And certainly if they report nausea, or if they're trembling, their hand is shaking, if they report having a headache, or they're not focusing on the conversation, or they definitely report insomnia, these are similar. So sleep problems are trouble concentrating. These things run through all of these diagnoses, which again is what complicates it. So the common symptoms of bipolar disorder, and so depressive, major depressive, and anxiety and bipolar are really among the top three of those diagnoses that also struggle with substance abuse. But the common symptoms and signs of mania is in bipolar disorder, are, as you've seen it perhaps in clients, feelings of euphoria, which are counterbalanced by extreme irritability when you speak. They tend to hold unrealistic and grandiose beliefs, dreams about the future that are nothing more than dreams. They may report a decreased need for sleep and increased energy. Definitely, they will be talking faster than me, and their thoughts will be racing. And they will show or exhibit or discuss times when they were acting under an impaired judgment or impulsive act. And then they too can be prone to anger and rage. And I want to read a couple of comments that I let go earlier. But Val Comer says, you're right. It is often just pray it away, too blessed to be stressed in relation to mental health. It is being talked about more. And Keldon Jones says socioeconomic factors also. I would wholeheartedly agree. And if you think about it these days, there are a lot of psychiatrists who are not taking insurance. And so you're talking about $150 a visit. And if you're someone that desperately needs help, I mean, that might be 4 visits a month. That's a chunk of change. And that's hard to come up with for some folks, for most folks. $150 a pop. And so naturally people are dissuaded from seeking help. Ms. Corner, I can never read your name correctly. There's a concerted effort to have more AA therapists and to educate on the need, African-American therapists, and to educate on the need for mental health. I'm glad to hear that. And I thought that was true. When I quoted a study from the 1990s, I knew that was outdated. I didn't know how much. I knew those percentages had gone down just because of the changes in society. And then Ms. Thrasher says, I think the most frustrating thing about being a therapist is knowing that patients, no matter what race, were going back to environments that would not help them in recovery, very, very much so. If you can get them ongoing help like a support group, it can help. And yet we're going to discuss that. That's great. Gail always says great kindness. So does Ms. Palmer and Kelvin Jones. So thank y'all for commenting. It certainly makes me feel like I'm reaching you, and like your knowledge is adding to what I am hoping to be knowledge. Now, we do know that currently, when we're treating folks with mental health disorders, we turn first to pharmacotherapy, antidepressants, the SSRIs, which are the older selective serotonin reuptake inhibitors, which have been largely replaced by the serotonin and norepinephrine reuptake inhibitors, or SNRIs, or bupropion. Now, let me say this to Kelvin's point. If this is prescribed for you and they move you from an SSRI to an SNRI, guess what? You probably then have moved from a generic drug to a brand drug, meaning you're paying considerably more. And again, this complicates the ability for people to get better. We talked about help with medication costs last week, and I hope if you didn't see it, go to my website at carepatrol.com or go to YouTube and search Sean Barnes Care Patrol, and you will be able to pull up my channel, I hope, and find that recorded. But here are the medications. We know what they are. You're all clinicians. I need not go through them, but to say that the point being that it's as to the cost and the inavailability of people to get treatment. Now, I want to ask y'all now, this is an easier question. How many Americans do you think have mental health and drug abuse issues, which is called a dual diagnosis? I've misspelled it here, forgive me. A dual diagnosis by percentage. What percent of Americans would you expect would have mental health and drug abuse issues? And I believe I'm right that we have around 335 million people in this country. So how many of those by percent do you think might suffer from mental health and drug abuse issues, which is also known as a dual diagnosis? Teresa Davis says 60%. Anyone else hazard a guess before I tell you the answer? 20%, 35, at least half, and maybe more. Y'all did a better job guessing than I anticipated. On a 2020 national survey on drug use and health, stated that 52.9 million people in the US, about 20%, aged 18 and over had or reported a mental illness condition in the past year. So in 2019, 52.9 million people had a mental illness of some sort, some sort. 17 million of those people had a co-occurring substance use disorder. So of that, about a third of those that had mental illness also had a substance abuse disorder. And NAMI, the National Alliance for Mental Illness, reports that 1 in 5 American adults have a mental illness, which is about what we said, about 20%, and 4% have a dual diagnosis. And I can't do the math this quick in my head, but whatever 335 into 17 million is, probably comes out to about 4%. We know that mental illness is closely linked to drug and alcohol addiction. For one thing, we know that people who have mental illness often self-medicate. And again, if you're looking at $600 for therapy and another $60 for a drug for a month, it might be cheaper to go down to the convenience store and get a six-pack. But the problem with that is that we know that there are certain substances, drugs and alcohol, that can lead to or make worse the mental health condition. And Keldon Jones says it's probably underreported, and I guess that's right. I think it is also underreported for reasons I said earlier. Now, people that are thought to have dual diagnosis or a co-occurring substance abuse and mental health issue, according to the Journal of the American Medical Association, they say that 50% of people with mental disorders are affected by substance abuse, that 37% of alcohol abusers and 53% of drug abusers also have at least one serious mental illness. And of all people diagnosed as mentally ill, 29% abuse alcohol or drugs. Now, these are sort of competing statistics on these pages. I include them all to show that the problem is sizable, if only because we don't know the size of it. And so if you don't know something, it's really a bigger problem than one that you can define and show and present data to back up your opinion. But when we're guessing, as we really are, it seems, we don't know. And so any of the answers that y'all gave that are on the high side, 50%, 70%, these could all really, truly be the case. It's a big problem. The National Survey on Drug Use and Health says that 45% of the US population has a dual diagnosis, that 23% of young adults do, that 7% of people over 50 do. And that's my bailiwick, as you know, with Care Patrol, is aging care. So 7% of the people we help have mental health issues along with substance abuse issues. Now, you can imagine the problem that person has moving into a community where perhaps they're not able to access their drug or alcohol of choice. The average dual diagnosis patient, so that when you recognize them when they come through your door, is a man, and he's 25 to 50, and he works full time. In fact, nearly 11% of people in the workforce are suffering from a dual diagnosis. They are abusing substances while at work, and they also have mental health issues. And we know, according to what we've seen above and discussed, that people with mental health issues have a higher risk of having a drug use disorder. Now, this is interesting. I'm not sure what the size of this poll was, but it's really a large poll or study, who found that of the 3 million adults that they surveyed who were employed who had a dual diagnosis, only 1.2 million received treatment for substance abuse or for their mental health disorder. And of them, only about 150,000 received treatment for both. That's a problem, because we know that people who have co-occurring disorders or dual disorders have increased rates of relapse in terms of their substance use issues, and they're much more likely to be hospitalized, to be homeless, or to have HIV or hepatitis C due to reckless behavior around drug use. And this is much more so, of course, than folks who don't have these issues. And I want to say here a couple things. One is on Monday, we'll be doing a mental illness among the homeless population. I hope you will be able to join us. And two is that there's a woman who may be on this call, but I haven't seen her name. A woman, Linda Thompson, she's the director or supervisor, I think, or one of the supervisors at the Talladega County DHR program. And she focuses on folks who have HIV. And I just want to thank her publicly for helping me to recruit speakers for next month, which is all clinical speakers. You won't hear me other than as a moderator. So October will be focused solely on clinical issues, some social work, some nursing, some pharmacy. But we will let that calendar out here shortly. But just want to make you aware that October will not be me, it will be us, but it will be guests of mine who are true clinicians and have the expertise, credentials, and wherewithal to lecture to you. We've already stated, I think, in detail that mental health and substance use disorders can occur together. And just to be clear about it, there's certain drugs, illegal drugs and prescription drugs, can cause people who have an addiction to them to begin to experience symptoms of a mental health disorder. And then there are those people who have a mental health disorder who may begin using substances to cope and then fall down that slippery slope into having an abuse or addiction issue. And the commonalities here are these, that in both of these folks, we see changes in brain composition, either due to the mental health disorder or due to the use of substances. We know that in each case, these folks, our clients, our patients, have genetic vulnerabilities to this, and then early exposure to stress or trauma, which we discussed. And these co-occurring disorders affect each other. When one goes untreated, the other typically worsens. When the symptoms of one increase, such as substance use, then the mental health symptoms usually increase in number and frequency as well. Substance abuse is closely linked, as we just said, but they don't necessarily directly cause each other. Alcohol and drugs, as we've said, people may use to self-soothe, to cope with difficult emotions, to change their mood. But anyone, and perhaps many of you, have had a hangover, and you know that in the end, the side effects are worse than whatever relief you got. And then alcohol and drug abuse increase underlying risk. They do not cause mental disorders, but they increase underlying risk. Again, because of a complex interplay of genetics, environment, and other factors. It is for some that the use and ultimately the abuse of alcohol and drugs push them over the edge into the mental health crisis. So, for example, there's evidence that those who have been for the last 10 years abusing opioid painkillers are at high greater risk for depression than others. And there is some study, many studies, in fact, that link heavy cannabis use to the onset of schizophrenia. And whether they cause directly or indirectly, they will worsen the symptoms of each of the other. And in terms of the pharmacotherapy, substance use typically weakens or lessens its ability to heal you. And so again, it's a spiral down a wormhole of pain. Oh, excuse me. Now, to recognize someone who's abusing substances, drugs or alcohol, we are going to see some physical changes about them. They may have bloodshot eyes. Their pupils may be abnormal. You may notice, if they're a patient you've met before, a sudden loss in weight or gain in weight. They may present just in a deteriorated fashion, not as they have in the past. They may have unusual smells about them on their breath or in their clothes or hair. And they may even have tremors or slurred speech. They may have impaired coordination. The social changes that you might probe to find out about would be if they've continued hanging out with their former friend group, if they're still active in whatever community, way that they were active before, if they still go out with friends. They may report, or you may ask if they've had any legal issues. And you will definitely notice things like money issues. And then the telltale sign is when they're approached and it's made known that this is harming a relationship, that they persist. I have a friend who is a recovering alcoholic and started drinking and lost his marriage, just like that. And these are the outcomes of drug abuse. Sometimes they have very real, significant effects to our lives. So I want to ask y'all now, maybe in a lighter way, if your patient or client has red bloodshot eyes, do you wonder if substance use or abuse could be occurring with this patient or client or friend or family member? And if you wonder that, do you ask it? So again, if you want to unmic, we'd love to hear your voice. But if you want to use the chat room, we understand. If your patient or client has red bloodshot eyes, do you wonder if substance use or abuse may be occurring? Or do you ask? Or would you assume, oh, it may be allergy season or something of that nature? So Catherine Cooper Lawton says she would ask for safety reasons. I expect, Catherine, that you've hit on the same answer that everyone else will ultimately hit on. Your clinicians. Oh, and Gail Thrasher says, when I worked with substance abuse patients, I did ask, but we also probably made them do a drug test, which was great. That would be obviously the next step. So symptoms of substance use disorders would be behavioral in many cases. So, drop in attendance or work, frequently getting into trouble using substances in hazardous situations like driving a car or a forklift or operating a deli slicer. I mean, anything of that nature. Being secretive about their behavior, being secretive in general, disappearing, changes in their appetite or sleep, unexplained changes in personality, sudden mood swings and irritability, and periods of hyperactivity followed by periods of low activity where they lack motivation, or appearing anxious, fearful, or worried for no discernible environmental reason. Abused substances include opioid painkillers. We all know that by now, don't we? ADHD medications. This is mostly kids in college or high school that abuse ADHD medications. Sedatives, recreational drugs like marijuana, methamphetamines, and cocaine, and then alcohol products. And the substance abuse problem, the questions we would ask, Gail, you probably know these well. And what we would say to the person, when we asked them, if we could ask them a series of questions, we might let them know that the more yes answers that they report, the greater the likelihood that we need to investigate whether this is an issue for them. And those questions would be, have you ever felt you should cut down? Do you need to use more and more? Have you tried to cut back but couldn't? Do you lie about how much or how often? Are you going through your prescription medication at a faster than expected rate? Are you doctor shopping? Have your friends or family members expressed concern to you? Do you feel bad, guilty, or ashamed about your behavior? Have you done or said things while you were using substances that you later regretted? or we're embarrassed about. Have these substance abuse issues caused you problems in relationships, at work, or in school? And have you gotten into trouble with the law? Those are the questions to ask, which I'm sure Gail knows very well. So I want to ask y'all now, how do you tell the difference after we've talked about these things? How do you tell the difference between a possible mental health issue and substance abuse issues? And does this complicate determining whether both may be present? And so, in other words, if you have someone who presents to you that you feel may have one or the other, how do you know which it is? Or how do you know if it might not be both? How do you get to that information? I'd like to know, because I like to know how y'all do what you do. So how do you tell the difference between a mental health disorder and a substance abuse disorder and a dual diagnosis? Maybe that's a better way to phrase it. As y'all contemplate that, I'll move on. The common risk factors for both and for dual diagnosis are genetics and environmental issues like stress and early childhood trauma. Mental disorders, these folks may rely on substances to self-medicate, but brain changes occur in certain mental illnesses that may actually increase the rewarding feelings associated with those substances. Keldon Jones says, not always easy. After sobriety is the best time to assess because drug use can present issues not present during sobriety. Perfect. Biological factors, we've discussed that all of us may have some biological predilection, genetic factor that causes us to react differently to substances or environmental stimuli than our neighbor. And then there are just changes that come over time, physical or behavioral or social, that may indicate the presence of a problem. It varies by the substance and it varies by the individual as to what may present. It takes time, in fact, to tease out what would be the difference. And the signs and symptoms would vary, as I said, based on the substance being used. So general warning signs that someone may have a co-occurring disorder would be the response to these questions. Do you use alcohol or drugs to cope with unpleasant memories or feelings, to control pain or the intensity of your moods, to face situations that frighten you, or to stay focused on task? Yes or no? Have you noticed a relationship between your substance use and your mental health? For example, do you get depressed when you drink? Or do you drink when you're feeling anxious? Or when you're plagued by unpleasant memories? Has someone in your family grappled with either a mental health issue or an alcohol or drug abuse issue? And here's the teller. Do you feel depressed, anxious, or otherwise out of balance, even when you're sober? Have you previously been treated? These are the questions that will help us get closer to knowing whether or not someone has possibly a dual diagnosis disorder. Amanda Stewart says, get details and timeline from client. Take time assessing and build rapport. Involve collateral sources as appropriate. Oh, I'm sorry, it moved up real quick. As able and appropriate. It's important to rule out possible medical issues as well. Thank you, Amanda. And Gail Thrasher says, that's a very interesting question. What comes first, the chicken or the egg? Substance abuse is a disorder in itself, and mental health issues are disorders in themselves, but there's an interplay between them. I think mostly we would look at the symptoms and the family history. Yes. Also, when I saw adolescents in an inpatient drug rehab, An MD already had made the diagnosis. And social workers can suggest to MD that there may be a diagnosis to look for, but only MDs can actually diagnose. It's true. But you have so much power as social workers to influence the healthcare system. It's amazing. And so little attention is paid to social work, in my opinion. So for dual diagnosis treatment for co-occurring disorders, which it's also known by, as we know and we discussed, we first need to, it begins with intake and assessment and evaluation by a medical professional, by you or by a medical doctor. And then you would assess the problem that the issue or the person is presenting, their overall health, any social factors present in their lives, their living situation, which was the point of, I think, Gail earlier, that it's hard to send someone back into the hornet's nest from which they came, knowing that it may lead them right back down that path of addiction. But whatever substance you abuse, we generally want to recommend detox. We all know what that is. And that prepares us for further treatment. In fact, in terms of dual diagnosis, inpatient detox has been more effective for maintaining sobriety. The time frame can vary. It could be anywhere from 30 to 90 days for an inpatient stay, and as much as a year for outpatient treatment. The National Alliance for Mental Illness says that people who have co-occurring disorders or dual diagnosis benefit from a high level of support and care that's delivered in inpatient rehabs, which involves living on site, receiving treatment and probably medication and 24/7 monitoring. And these places can adequately house people who are just substance abusers or people that have both mental health disorders and substance use disorders, people who are needing supervision medically, or people that require withdrawal management. So, inpatient treatment seems to be the winner here for those, again, who can afford it. For example, afford to take the time away from work, not just to pay for it. So you see, we have a limit in our system, which each of you know acutely already. So the treatment may begin at a high level, but it will transition into lower level of supports over time. And this could involve either partial hospitalization in terms of an inpatient approach, or if we could not do that, like in cases of, again, most of the people are 25 to 50 working men. How many of them can take off work for inpatient treatment? I don't know. But maybe a partial hospitalization may work, where you get intensive treatment for a week or a month for 4 to 6 hours a day, or standard outpatient, where you're going 2 or 3 nights a week for 3 hours for 2 or 3 months, or some lower level over time. And Cassandra Hinton says a problem with a lot of that population not having insurance. Exactly. Not having insurance for inpatient treatment. This is the problems. I can present to you the problems, but most of the time, all I can really find out are the problems that we have. It's the solutions that are in front of us that we need to get to. And this is where folks like you come in hand. You are the solution people. Recovery is lifelong. Aftercare, as we know, helps with preventing relapse. So there are mutual support groups like AA or NA that people can go. There's sober living homes. I used to live near one many years ago, which is just a home, a substance-free environment that's supportive for people that are trying to transition back into society. There's individual therapy. Again, the issue here is cost, although I know that there are programs through, like, for example, United Way. It's not accessible to everyone either, particularly if you live out in rural Alabama. There's group therapy and mindfulness-based relapse prevention. We discussed mindfulness a few weeks ago, and I think we did a mindfulness exercise. And if you did it with us, you might see how that would be a helpful coping mechanism, but I would say group therapy would be the most accessible in terms of there being AA programs most everywhere that people could go and feel at least a camaraderie with someone who's like-minded, so to speak. The behavioral therapy, if you can afford it, if it takes place, might be group therapy through a mental health program, or it may be individual. It may be cognitive behavioral therapy, which we discussed on another CEU, which essentially helps one address unhelpful thoughts and then replace those thoughts, thereby changing the behaviors that have traditionally been brought about by those thoughts. And then there's dialectical behavior therapy, which we did a CEU on, which is recorded if you want to see it on YouTube. Dialectical behavior therapy, in which Marsha M. Linehan, who created it, sort of brought together the meditation practices that she had learned into, and the way that breathing exercise helps calm the body, brought that into cognitive behavior therapy. And then there's community treatment programs as well. So what steps then, or tips, might you give someone dealing with a dual diagnosis? What would you say? You've assessed, you've identified, you know that this person is suffering. How can you help them? What do you tell them? Do you give them any tips? How can you help? Please answer in the chat room or unmute your mics. We'd love to hear what you have to say. I see that before one of you reminds me, it is 12:50. The password for today's evaluation, and I'm putting the evaluation link back into the chat room for you. The password is dual diagnosis. And that's with 2 capital D's, capital D-U-A-L, second word, capital D-I-A-G-N-O-S-I-S, capital D, dual, capital D, diagnosis. That is the evaluation link for today and password. So the things, and this is taking longer than I had hoped. I've already practiced it 3 times, but the things that we might do in terms of self-help would be to provide our client some tips. Tip number 1 is manage stress and emotions, which is not really much of a tip. It's kind of a broad brush. So let's break it down. When we come into stressful situations, remember the 4 A's: avoid, alter, adapt, and accept. And these will help us address the immediacy of that stressful event. So in avoiding unnecessary stress, we first got to teach ourselves and to learn how to say no. And this is probably something that would benefit all of us on the line here, is knowing our limits and knowing when we need to then give back to ourselves and say no to someone else. And then avoiding folks who stress us out. So we all have that person who, whatever it is about them, it's the opposite of who we are. And it's just hard to be around them, and yet they want to be around us. And so we've got to make the hard decision maybe to just say, hey, I'm sorry, I'm in a situation now, I can't be friends at this moment. And it's nothing, no harm, no foul. Take control of your environment. For example, let's say that driving to work stresses you out. Take a different route, or leave at a different time of day. Drive a different car. Somehow change that up. Ride with a friend. Change that up so that you don't experience that. So you can control your environment by saying no, paring down your to-do list, and then avoiding people who ask you to do things that stress you out. Then you can alter the situation. And by altering, we mean you want you to express yourself, to say to the person asking you to do something that you don't know that you can do, just say, hey, I'm sorry. Just thinking about that is overwhelming. It's very stressful. I really, I don't know that I can do that right now. Be true to myself. So instead of it bottling it up, because if you bottle it up, it's coming out. It's probably coming out through substance abuse or through some mental health, behavior, which is abnormal or not normal for you, but it's angry or aggressive. And then be willing to compromise. If you're going to ask other people to alter their behavior, like turning down the television, you need to be willing to participate. If they turn down the television and say, hey, can I sit in that chair where you're sitting, because then I can hear better, you got to be able to say, yeah, sure, because they're bending and you need to bend too. And then keep a balanced schedule, meaning, we work to live. When we start living to work, we're out of balance. Work-life balance is what's needed to keep a stressful or stressless life. In terms of accepting the things that we can't change, we did this prayer. God grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. I think that prayer sort of encapsulates, accepts the things you cannot change, and then learn to forgive those who have harmed you. And then lastly, the last A, adapt, reframe the problem. So it may not be the world's worst problem. It may not be that the sky is falling. And if it is, maybe you could reframe it. You might say, wow, the sky is so close, I can touch it now. I can take anything I want from the sky. Reframe the problem. It's not an opportunity, it's an opportunity. It's not a challenge. So the 4 A's: avoid, alter, accept, and adapt. That's tip number 1. Tip number 2 is connect with others face to face. Make an effort to reach out to friends and family. And then this deep breathing exercise I want to do with you, it's about tip number 3, which is make healthy lifestyle changes. Now, how many times have I told you on these CEUs that one of the ways to combat whatever diagnosis, illness, disease we said was to eat right, get sleep, and exercise. And that's true in dual diagnosis. It's true in everything. If each of us would simply eat right and exercise and get 7 to 9 hours of sleep, we could forestall or eliminate a lot of our mental health concerns and gripes. But here, for those of you who can't sleep, and to answer your question, Catherine, it is dual diagnosis. Today's password is dual diagnosis. Both words are capitalized. Here's a breathing exercise to help you sleep. Lay down in bed and close your eyes. One hand on your chest and the other on your stomach. Breathe in through your nose. The hand on your stomach should rise. The hand on your chest should move very little. Exhale through your mouth, pushing out as much air as you can while contracting your stomach. The hand on your stomach should move, but the hand on your chest should not. And continue to do this, to breathe in through your nose and out through your mouth. And try to inhale enough each time so that your lower abdomen rises and falls, and then begin to count slowly as you exhale, and have a good sleep. And tip 4, find new meaning in life. We know this to be true. This is true for each of us, finding people and places and things and ideas that interest us, influence us, that enrich us. We all need this, and certainly those with dual diagnosis do. And as we're at the end, I will say again, the code word is dual diagnosis. Both words are capitalized. Yes, you get all the slides, Cassandra, with every presentation. If you do the evaluation, when I send the certificate, I will also send the slides. So you can have them to get either the book titles or the tips or whatever that I can impart to you. My goal here, again, is always to give you value, make this worth your time, and give you tools in your personal and professional lives. And I hope we've done that today. I don't see that we have any other questions. I do appreciate you being here today. I hope you have a great weekend, and I hope you will visit carepatrol.com and sign up for our Monday class.